So my task today is to briefly overview what we suspect is happening to the brain during sepsis and how it may translate at the bedside. So first, I would like to acknowledge that we don't have a straightforward definition of brain dysfunction during sepsis or sepsis encephalopathy. Mostly in studies so far it was assessed via the Glasgow Coma Scale. And one can see here that about 1 out of 4 patients with sepsis may present with some brain dysfunction. It clearly depends on how one will define the disease or the syndromes. It clearly relates to the number of organ failings and clearly more likely to happen in patients with liver or renal dysfunction, as well as in patients with gram-negative bacteremia. So what do we know about brain inflammation during sepsis? First of all, there is no doubt, I guess, that the nervous system and the immune system are closely interacting one to each other. It's well known that the nervous system is controlling the differentiation of immune cells, the growth of tissues, and it's also well known that immune cells have a lot of receptors both on the surface and in the cytosol for a number of neuromediators. And it's also well known that the brain itself expresses a number of receptors for a number of pro and anti-inflammatory mediators. So one of the questions is, during sepsis, because as you know, sepsis is characterized by an overwhelming systemic inflammatory response following infection. So there is a huge amount of cytokines in tissues, in blood, but we know that the main brain structures are protected behind the blood-brain barrier. So one of the main questions in the area of sepsis is how these blood-borne cytokines or other mediators traffic to the brain, traffic to the limbic structures, allowing the brain to mount a response to try to counteract the systemic inflammation, and how this traffic of cytokines to the brain may cause brain damage and ultimately short-term mortality or long-term cognitive dysfunction. So there are many ways by which the cytokines may signal to the brain. One of the first is via the autonomic nervous system. It's well known that the terminal nerve ending of afferent fibers of both the sympathetic or the vagus nerve have cytokines, express cytokine receptors, and are able to sense the threat at the level of the tissues, signal the brain via the brain stem, and in particular via the nucleus tractus solitarius, neurons that have projections to the hypothalamus and the pituitary gland, and also to the hippocampus. All these areas are very important to allow the brain to mount a counteracting response to the systemic pro-inflammatory context. And for example, in patients who died from an abdominal sepsis, we and others were able to nicely show huge or substantial expression of pro-inflammatory mediators, just like tumor necrosis factor alpha or IL-1 beta in many brain structures, including supraoptic nuclei in the hypothalamus. Another way by which the cytokines traffic to the brain is by a breakdown of the blood-brain barrier. And this breakdown mainly may occur by activation of the complement system and more specifically by expression of C5a in cells lining the blood-brain barrier. There are clear evidence in humans. If one uses MRI in patients with, for example, community-acquired pneumonia and severe sepsis, one can see that very early in the time course of the disease, day 3 in that patient, signals on MRI in the virtual Rubin spaces, nicely or strongly suggesting vasogenic edema and disruption of the blood-brain barrier. And experimental data was also well shown that receptors for C5a are expressed by cells lining the blood-brain barrier, and also on the left panel on the microglial cells. And finally, cytokines, of course, will enter via the circumventricular organs, as you know, areas that are lacking a blood-brain barrier, and also via specific carriers who allow the transport of tumor necrosis factor, for example, or IL-1 beta, or even IL-6 and IL-10. And so via these areas lacking a blood-brain barrier was nicely shown that these areas are expressing CD14, Toll-like receptors, and other cytokine receptors. So they are able to identify the cytokines in the blood neighboring these areas. And then the cytokines progress more deeper into the brain, and in particular to the limbic structures. So these blood-borne cytokines basically will first activate the microglial cells. As you know, these are the resident macrophage of the brain and astrocytes. And these two types of cells then will regulate the neuronal function and may either cause a physiological adaptative response that will allow to deal with the systematic inflammatory response, or may cause damage to the neurons with subsequent brain dysfunction and multiple organ dysfunction. So again, this slide is summarizing how in these circumventricular organs the time course of expression of pro-inflammatory cytokines. So basically, very early following sepsis, one will see expression of pro-inflammatory cytokines like IL-1 beta in areas like the area postrema, for example. And in the following hours, expression of inos. And we'll see in the next slides how nitric oxide produced via inos may be neurotoxic and may cause brain dysfunction in patients with sepsis. So, for example, in our lab, we nicely shown in rats that these activation of the hypothalamus, like other limbic structures following sepsis, is really proportional to the intensity of the systemic inflammatory response. So we took animals with mild sepsis or severe sepsis, and we looked at mRNA for corticotropin releasing factor in the PVM, and one can see how the expression of these CRF relates to the intensity of sepsis and intensity of the systemic inflammatory response. What is also known is that indeed at the beginning, in the early time course of the so-called cytokine storm, there is a proportional response of neurons, in particular in producing the counter-regulatory hormones. However, beyond a certain point of activation, happened a decline in the capability of the neurons to produce these important mediators. And this correlates with the presence of neuronal apoptosis in a broad variety of structures that are important in the regulation of the homeostasis in severe infection, for example, the locus cells, but it's also true for PVN cells or supraoptic nuclei cells. And in the vessels neighboring these neurons, one can notice a substantial expression of the inducible isoform nitric oxide synthase, which is going to produce huge amount of nitric oxide. And nitric oxide, this is work coming from Brazil, where in animals again, one can see on panel A that there is in the PVN cells following LPS huge activity of inos. They block the activity of inos using a specific inhibitor. And what they could notice is that the downstream production of ACTH or corticosteroid in animals then abruptly rose. And this nicely demonstrated that nitric oxide that was produced in relation with the overexpression of inos was basically preventing or inhibiting the production of these important hormones. And the same for vasopressin, in patients with septic shock compared to control patients is markedly depressed in the PVN cells. The cytokines in the brain also causes other damage, and in particular in the brainstem. One can see here in patients who died from septic shock this lipidic vacuolization of the brainstem that are very typical of leukoencephalopathy of the pulse, and these damages were nicely correlated to the amount of IL-1 beta circulating in the blood of the patient before the patient died. The cytokines and the overexpression of inos with subsequent nitric oxide production is associated with substantial oxidative stress in important brain areas, as for example suggested in that work where they use the ratio of superoxide dismutase over catalase as an index of free radicals production in brain structures. And compared in the first row to sham animals, one can see that in the cerebellum, hippocampus, and cortex, there was a huge amount of free radicals that were produced 6 hours after sepsis was induced in these animals. And this is causing, of course, mitochondrial dysfunction. Again, this is from Fernando Pozza group in Rio, in Brazil, and the Neuroscience Institute, where it's nicely demonstrated in animals with sepsis that actually there was a dissociation between an increased consumption of oxygen and production of ATP, was decreased phosphox efficiency, and also decrease in the mitochondrial content, and finally leakage with depolarization of the mitochondrial membranes. So all these phenomena are occurring in sepsis as a consequence of cytokines trafficking to the brain, triggering the inos and overproduction of nitric oxide, and then mitochondrial dysfunction. Very interestingly, that these cytokines induce damage to the brain are basically interacting with a number of other insults. The brain is intoxicated during sepsis, and this was demonstrated by many works. Just pick up one study, an old one nicely demonstrating that if one is going to check the amount of metabolite like amino acids like these ones, one will see that they are elevated in patients with sepsis and even more elevated in those with brain dysfunction. And this correlates with mortality, but this is not surprising, of course. And also, there are a number of vascular damage to the brain in patients with sepsis that are due, of course, to the brisk variation in blood pressure, but not only. Many other factors, and sometimes even in patients without atherosclerosis, can happen major, large brain infarct. Or more subtle ischemic damage, more subtle hemorrhage to the brain, and DIC causing, of course, also damage to the microcirculation in the brain. So all these inflammation, ischemic damage, metabolic-related insult to the brain are interacting in a vicious circle towards damaging the neurons and killing the neurons, and then causing brain dysfunction, multiple organ dysfunction, and eventually death. How does this translate into the brain, at the bedside, very briefly? So we looked at this in a number of patients with septic shock. So one can see first that a number of patients, almost 1 out of 2 patients with severe sepsis, is presenting with some symptoms of brain dysfunction, including confusion or delirium in almost 50% of patients. Altered mental status is again also very frequent, whereas coma is less frequent. And looking, this is very interesting, at brainstem function and brainstem reflexes, which can be very easily assessed at the bedside. One can see that, again, there is major abnormalities in brainstem function, absence in eye movement, no blinking to strong light, no oculocephalic responses in a majority of patients. Using electroencephalography, one can see different patterns, triphasic waves, theta waves, or burst suppression. And so I can go quickly to this, and again to show that these abnormalities, and in particular the absence of cough reflex, which is very easy to assess at the bedside, or the absence of oculocephalic responses, are major signs, major prognostic factors in these patients, either predicting death for absence of cough reflex or predicting persistent brain dysfunction for the absence of oculocephalic responses. So what we're doing in my units in patients with septic shock is basically, if the patient is sedated on a daily basis, we stop the sedation, assess the patients, and if there is signs of brainstem dysfunctions or obviously motor response abnormalities, then we go to lab investigation and MRI. In non-sedated patients, we assess the patient via scores of delirium, like the CAM-ICU score, and using this scale, we decide whether we bring the patient to the MRI department for MRI assessment. So in conclusion, sepsis induces brain dysfunction in a vast majority of patients, mainly via breakdown of the blood-brain barrier and neuronal and microglial activation. And the brain damage are related to a number of events, including inflammation, alteration in hemodynamics, and alteration in metabolism. Thank you very much.